Good morning. Welcome to the Center for Clinical Trials seminar. We're very fortunate this morning to have Dr. Lisa Cooper. She's a professor of medicine, epidemiology, health policy and management, and health behavior and society here at Johns Hopkins. She's also a core faculty member at the Welch Center, where her desk is situated, I think. And she's the author of over 100 peer-reviewed publications. And she's an internationally known expert on the effectiveness of patient-centered and culturally targeted strategies for improving health outcomes and overcoming racial and ethnic disparities in healthcare. She's received a number of awards for her work, which is pretty exciting, and it's exciting to have her here, and we can all bask in her glow, including election to the American Society of Clinical Investigation, the Delta Omega Public Health Honorary Society, the Institute of Medicine at the National Academy of Sciences, and perhaps most important in many ways, a MacArthur Genius Award a couple of years ago. So that's one of the reasons we're particularly lucky to have her, because I'm sure her schedule must be completely full with invitations. And we've been trying for a couple of years to get her here, so she's finally free. Anyway, I also wanted to say something about her mentoring. She's a devoted mentor to junior faculty, and I know this is an important part of what she does, postdoctoral fellows, residents, public health, and medical students. She currently has an NIH grant to conduct her research, and we'll be hearing about one of those projects today. So without further ado, Dr. Cooper.
I don't think I need it, but I might just clip it on just in case. Well, maybe I'll just hold it. Anyway, it's nice to be here. Thank you for having me. And I chose the topic, Evaluating Interventions to Reduce Healthcare Disparities in the Era of Comparative Effectiveness Research, because in a lot of ways I feel like this is what I've been doing all along, even before it became called Comparative Effectiveness Research. So here's a quick overview of what I hope to talk with you about today. First, talk a little bit about what health and healthcare disparities are. What has been the presumed or potential role of comparative effectiveness research in reducing healthcare disparities, how we might integrate patient-centeredness and cultural competence into interventions. Then I'll talk about one randomized trial that we've done to improve patient-centered care and hypertension control in underserved primary care patients, and then just complete with some conclusions and implications for future research. So first, I'm sure people here are pretty well aware of this, but we just all want to be on the same page. What do we mean when we say health disparities? Health disparities are differences in health that occur by a variety of different characteristics of the population, by gender, race or ethnicity, income or education, for example, geographic location or disability status or sexual orientation. And that's how it was defined by the Surgeon General back in the early part of this decade. And a health disparity population is a population where there's a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general population. So in particular, a lot of my work has focused on racial and ethnic disparities in health, and those have been extensively documented. As you know, some of the indicators that have remained, that have shown disparities for over 100 years in this country include life expectancy at birth, where American Indians, for example, and African Americans have much lower life expectancy at birth than European Americans. Same for infant mortality rates. Mortality rates tend to be higher for a number of diseases for ethnic minority populations compared to whites, as well as morbidity rates. And I'm not going to go into the specific conditions here now, but we'll talk about a particular area when we get to the study that I plan to discuss in more detail. So here's a framework for understanding racial disparities in health. This is adapted from some work by David Williams, who's a well-known sociologist now based at Harvard. And basically what it shows is that health disparities are influenced by complex interactions among several different factors at several levels. So environmental factors, things like housing and food availability and exposure to pollution, for example, or crime. Socioeconomic factors that are unevenly distributed across groups. Psychosocial factors, stress, discrimination. Cultural factors, health risk behaviors that differ across racial and ethnic groups. Biologic factors, which tend to play a smaller role but can be influenced by a number of the other factors. And then access to health care and quality of health care, which we're pretty well aware of because of the huge national debate about a lot of this. What I'm going to focus on today is looking at the role of quality of health care and how we can intervene there in reducing some gaps in overall health. So what are health care disparities? And a few years ago, the Institute of Medicine actually did a study that is pretty well known called Unequal Treatment that came to the conclusion that health care disparities are differences in care that emerge not from differences in access. So they're not talking about things like people having health insurance or having a primary care physician, for example, and not from clinical appropriateness or patient preferences, but rather from inequitable processes within the healthcare system, which they thought may be due to things like bias or prejudice, stereotyping, uncertainty, or problems in communication and clinical decision-making on the part of providers. And they did an extensive literature review that documented all these differences and found that even after controlling for things like clinical appropriateness and patient preferences, that differences in care across racial and ethnic groups persisted. So what did they find? They found that these disparities in healthcare were pervasive. They occurred across conditions, numerous conditions. They occurred across populations. They occurred regardless of setting. They occurred across different levels and types of care, all the way from very simple preventive measures, things like getting a flu shot, to more complicated tests and procedures, things like getting a renal transplant, for example. And then also across different dimensions of healthcare quality. So when they looked at things like the timeliness of the treatment, the safety, for example, and patient-centeredness, which we're going to spend more time talking about, they saw that racial and ethnic minorities, for the most part, tended to receive poor quality of care. So like health disparities, health care disparities also result from numerous complex interactions across numerous factors. And this is a model that some colleagues and I, some of the names you may recognize, worked on, that modified the Institute of Medicine's model of access to care to try to address some of the issues that are related to racial and ethnic minorities in particular that hadn't been included in this model before. So there were things like cultural beliefs and language and literacy and attitudes and beliefs that hadn't actually been included among the patient's personal and family barriers. These structural and financial barriers are system-level barriers that were pretty well known. And we just we expanded this model and suggested that these are different issues or different intervention targets that could be addressed to overcome disparities in outcomes. And in the area of quality of providers, we expanded that to include cultural competence, which, again, I'll tell you more about that, and communication skills, as well as bias and stereotyping behaviors. And then for outcomes, we expanded those beyond just health status measures to look at equity of services, but then also patient views and experiences of care. So just to let you know, disparities research has been going on for many decades, but it's actually been evolving over time. And it started out where a lot of the work was basically defining health disparities, describing the populations, and just being very descriptive in nature. The research has evolved over the last, I would say, 15 to 20 years into more of understanding mechanisms, and then now into reducing, so actually developing interventions. About 10 years ago, there were very few interventions that were specifically designed to reduce disparities in care, although there have been a number of interventions that were done in disparity populations in efforts to improve health. Few of them had specifically said that they were intervening in order to reduce disparities. And there was really a need to perform more rigorous studies to actually evaluate these interventions. So the field has been evolving into more of an interventions paradigm. And so when the term comparative effectiveness research came about, a lot of people wanted to understand how this new way of looking at comparing effectiveness within healthcare could be applied to the healthcare disparities problem. So what is comparative effectiveness research? It's research that evaluates and compares the clinical effectiveness, risks, and benefits of two or more treatments or services. And they could be anything ranging from healthcare interventions, care management and delivery, to specific medical devices and pharmaceutical agents and things like that. So we don't really have the answer to this yet, but a lot of people have conjectured about how comparative effectiveness research could reduce healthcare disparities. So one of the issues that's been brought up is that in order to do that, we actually need to require better capture of data on treatment and outcomes among racial and ethnic minorities. So a lot of the data that exists on treatment, for example, in the healthcare system, we don't know how racial and ethnic minorities are treated because the collection of race and ethnicity data has not been done in a consistent manner or done in a rigorous manner. So that would be one way to actually have comparative effectiveness research contribute to this effort. Another recommendation has been to promote and incentivize subgroup analyses. So a lot of large clinical trials and a lot of large studies on quality of care have actually not looked at subgroups of disparity populations, for example. Another area has been to advance the science of recruitment and retention of ethnically diverse populations in clinical trials. As you know, that's been an area that's received a lot of attention because we know a lot of the scientific literature does not include adequate representation of people from these groups, which actually raises questions about the relevance of the findings to these populations. It's been suggested to increase the number of minority investigators, perhaps because these individuals may come from the communities that are traditionally underrepresented in research. They may have research interests that are related to health disparities populations, and they also may enhance the cultural sensitivity of the research. It's also been suggested to increase the number of investigators who are doing community-engaged research, because this is often where the populations that are disparity populations can be reached in order to participate in research. And then it's also been suggested to test patient-centered approaches and to test culturally tailored or targeted approaches. So we're going to talk about patient-centeredness, and we're going to talk about cultural tailoring or targeting or cultural competence. So I'm going to use those terms somewhat interchangeably. So what is patient-centeredness? As you know, this is one of the dimensions of healthcare quality that was put forward in the Institute of Medicine's report, Crossing the Quality Chasm. So it's providing care that's respectful and responsive to individual patient preferences, needs, and values, and ensures that patients' values guide all clinical decisions. It includes things like patient-centered communication, which may be on an interpersonal level between a doctor and a patient, or it could be communication between the entire healthcare system and the patients and families. It includes patient-centered education, consumer empowerment, and also systems of care measures. So patient-centeredness can be considered on an organizational level as well as an interpersonal level. And so on an organizational level, the services are aligned to meet patients' needs and preferences. So these are some of the things that we would consider to be patient-centered from an organizational standpoint. And then within interpersonal interactions, what it says is that the clinician or other health professionals will understand each patient as a unique human being. So, and then these are some of the components of basically of doing that. So now we're going to talk about cultural competence or culturally targeted care. And similar to patient-centeredness, it can be defined on an organizational or on an interpersonal level. So, and these dimensions have some overlap, you'll see, but there are some distinct differences. So for health system cultural competence, that's been defined as the ability of healthcare providers and organizations to understand and respond effectively to the cultural and linguistic needs brought by patients to the health encounter. So it's similar to the patient-centered approach, except for there's a particular focus on the cultural and linguistic needs. On the level of interpersonal cultural competence, it's the ability of individual healthcare professionals to establish effective interpersonal and working relationships with patients and with each other to supersede cultural differences. So similar to patient-centeredness, there's the organizational and interpersonal dimensions. And again, within the organization, it's the ability of the healthcare organization to meet the needs of diverse groups of patients. And it includes a lot of different things. So, diversity of the workforce, language assistance, staff training, regarding culturally and linguistically appropriate services and educational materials. And then within interpersonal interaction is the ability of a provider to bridge cultural differences. So it's not, it extends a little bit more beyond just understanding the person as a unique person, but basically appreciating diversity, understanding the meaning of culture, awareness of health disparities and discrimination, for example. Okay. So why do we care about patient-centeredness and cultural competence in healthcare disparities? Well, one thing is that it's been documented, like I mentioned before, that there are actually disparities in the level of patient-centeredness and cultural competence that patients from minority groups experience in care. So there have been studies over the last couple of decades showing that ethnic minorities and poor persons actually experience less patient-centered and less culturally sensitive care. So studies looking, using survey data show that these people from these groups experience less participation in decisions about their care. They have more communication and language barriers with providers. They report lower levels of respectful treatment. And when you actually measure the communication behaviors in these visits, you find that they are what we call less patient-centered. And that basically means that the visits tend to be more oriented towards the typical biomedical agenda. So the conversation tends to be more focused on things like medications and physical complaints, and things like emotional needs and psychosocial issues are not addressed to the same degree. Also, there's less involvement in the patient on the patient's part, in decision making, less efforts on the part of the clinician to get the patient's opinion and to make sure the patient is understanding or going along with the plan. So we've seen that, and there have been very few interventions that have actually focused on these particular dimensions of care. So a lot of interventions have focused on things like, improving the way that doctors prescribe medication, for example, or they might focus on educating people to change their behaviors, but not necessarily on actually involving them more in decisions about treatment or actually trying to meet the patient's cultural or linguistic needs. So I'm going to shift gears for a moment here and talk about a particular area that I've been working on interventions in, and that's in cardiovascular health and healthcare disparities. So cardiovascular disease is, as everyone knows, the number one contributor to mortality in the U.S., and also it's actually the area in which there are the largest ethnic disparities. So in particular, African Americans and persons of low socioeconomic status suffer a disproportionate burden of morbidity and mortality from cardiovascular disease. And it actually accounts for 35% of the excess in overall mortality in African Americans. And that's mainly because of poor control of hypertension. And as we know, a large proportion of our population has hypertension. About a third of the adult population has high blood pressure. Only 50% of these individuals actually have it under control, meaning less than a systolic of 140 and a diastolic of 90. And the control rates among people who are actually getting treatment tend to be lower for African Americans and Hispanics when compared to whites. So whereas you will see among people who are getting treated, about 35% of them are controlled. For minorities, it tends are uncontrolled. For minorities, it tends to be 40 or slightly over 40%. So, and it's really believed that these disparities in care of hypertension do contribute significantly to cardiovascular disease outcomes. So we wanted to focus on reducing disparities in hypertension control. And we conducted a randomized controlled trial. This was a few years ago with a factorial design. And the goal was to recruit 50 primary care clinicians and 500 of their patients who were either ethnic minorities or poor persons with high blood pressure. So to do this, we went to urban, community-based primary care clinics. We specifically targeted clinics that we knew served a large proportion of their patient population was either ethnic minority or patients living in poverty. And we recruited those practices and then aimed to recruit the clinicians practicing in those practices to participate in the trial. The interventions that we wanted to test were related to communication skills training for clinicians and patient coaching and activation for patients. And the reason we focused on these was because of the prior work that we and others had done showing these disparities in patient-physician communication and in minority patient involvement in decisions. The other reason we wanted to focus on that is also because it had been shown that involvement in decision-making is actually related to positive outcomes. So we know it's been related to adherence and also to better disease control, but most of those studies, again, had not involved minorities or low-income patients. So the main outcomes for this study included patient-physician communication behaviors, patient adherence, and blood pressure, as well as blood pressure control over follow-up. So this is the design of the study. We planned to enroll 50 physicians and to randomize them to either get communication skills training or to have to be randomized to a minimal intervention. And the minimal intervention, I'll tell you more about what each of these are. And then after randomizing the clinicians, we would then randomize the patients in each group. So the patients of each physician would then either be randomized to get coaching by a community health worker or to have a minimal intervention. And so I'll tell you more about the specific interventions as we move forward. So for recruitment, this is really important because we talk about the fact that it's been really hard to engage these patient populations in research. Just wanted to tell you a little bit more about what's involved with that. So what we did was after going around and meeting organizational leaders, we decided that the best way to recruit the clinicians would be to have a letter that would come from the medical director of each organization or practice along with myself, the principal investigator. As part of an incentive to be involved in the study, we would offer CME credit for participating in communication skills training, and we would also offer them individualized feedback on their own communication styles. They, in informal meetings with these practice leaders, we found that this is something that they thought their providers would find valuable. The organizations were also given an incentive for having physicians participate in research. And so this was estimated at about $200 per physician. And this is because participating in this, like actually allowing yourself to to be videotaped with a standardized patient takes time away from seeing patients, and then also allowing yourself to be observed during the trial as well. So that was what we did for recruitment of physicians. For patients, we identified eligible patients using claims data on hypertension diagnoses. This was before a lot of these practices did not have electronic medical records, so it actually meant like going through charts at some places, and some other places did have electronic data. And so we identified people from claims data and from clinical records. We mailed invitations to the eligible patients that we found, and then per the IRB protocol, we basically had to wait for them to have the letter in hand for at least a week. They had a refusal postcard option that they could turn in to say they didn't want to be contacted. If we didn't hear from them in a week, then we would call them on the telephone to follow up. And after going through the recruitment script over the phone, if they said they were interested, they were asked to arrive an hour and a half early for their next scheduled appointment. And then basically we also supplemented that with on-site recruitment. So we ended up going to practices and just basically waiting in waiting rooms to see if we could identify eligible people. And the patients were paid $25 per interview. So they had a baseline, a 3-month, and a 12-month interview. So you probably can't read this, but I thought it was worth just showing you that, we had assessed 133 primary care physicians for eligibility, and we ended up excluding 83 of them. There were very few that didn't meet the inclusion criteria, so just things like whether they practiced at least 20 hours a week and whether they intended to stay at the practice for the next year. But there were a number of people who refused. They just were too busy or didn't want to be observed, and didn't want to have their communication observed. And there were other people who we just never heard from, even though we continued to email them or call them. So we ended up actually reaching our recruitment target. We randomized 50 clinicians, 25 to the intensive and then 25 to the minimal group. But as you can see, there's loss to follow-up, and so we ended up basically with 22 clinicians in the intensive group and 19 in the minimal intervention group. So people either left, they still ended up leaving the practice even though they hadn't said they were going to leave. They became ill. There were a couple of people that just withdrew from the study. So in terms of patient enrollment, we assessed 980 patients for eligibility. You can see a lot of this was done by phone, but we actually did have a few people on site that we recruited in some practices because we had trouble getting access to the data. We ended up, however, excluding 700 of these people. Many of them didn't meet the inclusion criteria. That means they either, even though the claims data said they had hypertension, they actually didn't have it, or the primary care clinician that was noted on their form was actually, they weren't a patient there or something like that. There were a few people who actually flat out refused, and this is really interesting. There were a lot of people who said yes on the telephone that they wanted to participate, but they actually never ended up showing up for their visit. So we only randomized 279 patients. Now, a lot of this is because we had physicians who were lost to follow-up before we could begin patient recruitment, so that reduced our numbers as well. But you can see that a lot of people actually, even once you reach them and they say they are willing to participate, they don't actually show up. So we randomized 140 people to the intensive intervention and 139 to the minimal intervention, and then we can talk more about the follow-up rates as we move forward. So, and there's also, loss to follow-up over time as well. So let me tell you a little bit about the interventions and then how we evaluated them. So the physician intervention. So all the physicians at baseline were videotaped with a standardized patient. And then what they agreed to do is actually to have all of their enrollment visits for their patients audio taped. And this came to about 5 to 10 patients per physician. For the intensive intervention group only, they got an interactive CD-ROM program that featured a video of them interviewing the standardized patient and actually gave them particular feedback on their own behaviors with the patient. It was accompanied by a workbook that had exercises to guide them through a self-assessment process. They also had a video glossary that was part of this program where they could look at examples of other doctors using exemplary communication behaviors. And the entire administration time for this program was estimated to be about 2 hours. So they're supposed to complete the program, complete the workbook, and turn it into us, and then they got the CME credit. And we had ways of tracking whether or not they had actually spent time on using the CD-ROM because we could capture that electronically. Then for the minimal group intervention physicians, they actually got the intervention at the end of the study. So we promised that to everyone. So these are the behaviors that were targeted. For data gathering, we focused on having them use open-ended questions to make sure they probed the patient's perspective on the disease and on its treatment. For educating and counseling, we had them focus on giving the information in short, clear statements and allowing the patient to have opportunities to ask questions. For rapport building, we focused on telling them to show empathy, to make an emotional connection and give support to patients when they disclosed a particular challenge. And then we also focused specifically on partnering with patients to share decision making. So we demonstrated behaviors where clinicians would be soliciting the patient's opinion, listening to the patient's views, and using participatory strategies. So for the patient intervention, all patients got a monthly newsletter that was it was written at a 6th grade reading level. It had a Q&A column, recipe exchange, health tips, and reminders to keep their appointments. So that was basically the minimal intervention. And then the intensive intervention patients, they got coached by a community health worker. So they had a 20-minute visit with the community health worker before their enrollment visit with the clinician, where the community health worker basically helped them to prepare their questions, made sure they had their concerns written down, and then basically had them practice what they were going to say when they went in to see the doctor. That was followed by a 10-minute post-visit debriefing to figure out how everything went and whether they would try to do something differently the next time. And then the intensive intervention also included 5 telephone follow-ups for basically by check-in. And then the patients in this group, in addition to getting the monthly newsletter, also got a photo novella. So it was like a dramatic story written. It's sort of looks like a comic book, but it follows a particular patient's story that has a lot of issues that were salient in the community. So things like how to deal with stress, how to find a safe place to exercise, whether or not you could drink alcohol and also take your hypertension medication, things like how to tell the doctor if you're actually not taking the medicine or you're concerned about side effects. So, and that also was written at a 5th grade reading level. So the community health workers, what they were asked to do is basically help the patient to identify key concerns with regard to the doctor-patient relationship and their management of their disease, help the patient to build skills in joint decision-making. They would give support to the patients when they did well and encourage them that, it was perfectly reasonable for them to raise their concerns or ask questions, and they would cover a number of different topics. So knowledge and beliefs about health and high blood pressure, treatment with medications, diet, physical activity, weight loss. They also talked about smoking cessation, since this was a cardiovascular risk reduction study, alcohol reduction, and stress reduction. So the main outcomes for the study over 12 months were, first, a change in the physician's patient-centeredness scores, and then change in the patient's rating of the doctor's participatory decision-making style. Change in patient involvement in care. This is also self-reported by patients. Adherence to medications using a self-report measure, a well-established self-report measure. And then change in systolic and diastolic blood pressure as well as blood pressure control. And blood pressure was measured at baseline by trained observers and also at follow-up. So we had the patients, their baseline visit was at the clinic, and then their follow-up visits were at the GCRC, the outpatient GCRC here at the hospital. So we covered transportation, and they would come in and the trained observers would use an automatic blood pressure monitor and use a standardized protocol to measure the blood pressure. And then basically this protocol is used in several clinical trials of hypertension. And what we do is we take the average of the three measurements that are used by the machine.
So Lisa, how did you measure the first and third of those items?
So the first item was measured by the videotape encounter with a standardized patient.
So
and the audio.
You repeated that?
Well, so this is it. We had wanted them to see the standardized patient again after training, and that was absolutely off the table. They refused to see a standardized patient more than one time. So that's why we said, okay, well then what we'll do is, can we just audio record your actual patient visits? And they said, okay, that's fine. As long as the patients agree.
They audio take all their visits?
All of their hypertension patient visits. Yeah, so the patient an eligible patient was coming in. So what we did, we used the rotor interaction analysis system. I don't know if are you guys familiar with Deborah Rotor's coding system? And so there are several different measures, but the one that I'm focusing on is a patient centeredness score, and that's calculated by, the coders listen to the audio recordings. They categorize everything that's said by the doctor or the patient into these different categories. And then the patient-centeredness score is created by basically adding up all of the focus on all of the psychosocial statements, the rapport-building statements, all of the patient questions, all of the sort of open-ended questions by the doctor, and then dividing that by the biomedical, just the strictly biomedical conversation.
And the third one, the change in patient involvement in
care. So that's self-report. That's a scale that's it actually has three subscales. So doctor facilitation behaviors, patient information, and then patient decision-making behavior. So patients just kind of tell you whether or not they thought the doctor did certain things and whether they did certain things at their most recent visit. And, both of these measures, the PDM and the PIC, have been used in a lot of other studies. The PDM measure has been shown to predict continuity of care over time. It's been shown to predict patient satisfaction. It's been shown to predict adherence. So for the data analysis, of course, a randomly assigned treatment group is a main independent variable, and we use intent to treat principle. The primary endpoint was 12 months of follow-up. So for continuous measures, it was a change from baseline. And then we use mixed effects regression models to assess the intervention effect and also account for nesting of patients within physicians. For missing data, it was assumed to be missing at random. And we did sensitivity analyses. We used hierarchical models that use data from all time points. So if somebody came in at 3 months but not at 12 months, we incorporated that data. For continuous measures, and then we use multiple imputation for dichotomous measures. This is just to check the validity of our results. So here are some characteristics of the physicians. You can see they're about 42 to 44 years on average. They've been in practice 10 to 12 years. Just over half are women. We had a good sort of ethnic diversity here. Usually this is not really the case in many trials, so that was good. Most of the docs are internists, general internists. A few were family physicians, and most of them were U.S. medical graduates, although we had about a quarter of them were international medical graduates. And there weren't many differences between the groups. I didn't show this here, but I think 80% of the intensive interventions docs were board certified, and 100% of the minimals were board certified. So in terms of the patients, you can see, we end up with like much smaller numbers here because we didn't reach our recruitment target. But you can see they're about 60 to 65 years old on average. High school education is the mean level. Again, this is pretty typical for primary care, about 65 to 70% women. We had a high percentage were African American. About a third had Medicaid insurance, and only about 20% of them, 20 to 25%, were actually employed. So an older and disabled group.
Can you go back to your previous slide?
Sure.
So you're showing it for the people who actually finished the study. What about the
Yes.
people who started?
Yes, we actually showed in our design paper, we showed the people who started the study. It's really not that much different from these people.
Characteristics that predicted the ones that were going to drop out?
Actually, I don't think we did. I mean, we had just anecdotally, I think there was one woman who became ill, and there was another person who went on maternity leave and didn't come back. But we had like 6 people drop out of one group, and I believe 3 out of the other. And I don't think there were any differences in those two. Yeah. So, and then these are kind of just the other characteristics. You can see there's a pretty high body mass index here. This is the physical component score on the SF-12, and you can see it's about 40, which is the population mean is around 50, so a little bit lower than average. And then the mental health score is about average for the population. There's a high level of comorbid diabetes, and it was a little bit higher in the most intensive. In this group, in the patient-intensive physician minimal group. And then comorbid depression was, again, a little bit higher in these groups than in this group. So what did we find? We're going to be running out of time soon. So for the physician-patient centeredness ratio, we looked at, at baseline, you can see that the intensive group actually is doing better than the minimal group, because what we look is for the ratio to be close to 1, and that means, actually the minimal group was better than the intensive group, I'm sorry. We look for the ratio to be close to 1. If it's greater than 1, then it means that it was more patient-centered. So the minimal docs were actually better to start with than the intensive group, but when you look at them compared to how with the standardized patient compared to how they did with their actual patients, they actually they did worse, so they got worse with their actual patients in the minimal group to a greater extent than the intensive group did. So, and it's true, people are sort of on their best performance, and they're, everything is sort of, they had the 30-minute block to see this standardized patient, but when they're seeing their actual patient, they've got their regular schedule going on, and there are lots of other things going on. So, but anyway, it looked like the intensive group showed less reduction in their performance than the minimal group did. As far as change in the patient's report of participatory decision-making over time, you can see this is the most intensive group here in red, where both the doctor got trained and the patient got coached. They showed a greater increase in that patient participatory decision-making score compared to the intervention group that got either, the patient either got coached or the doctor got trained. And you can see this is the minimal group, which actually got worse in terms of the doctor's participatory decision-making style over time. And there's a similar pattern that's shown with the patient involvement in care scale. So this is the doctor facilitation scale, and you can see a similar pattern where the most intensive group improves significantly compared to the minimal group. The same for patient information giving improves significantly in the most intensive group. compared to the minimal group. And then for the patient decision making, we didn't really find a significant difference, but it shows a similar pattern. This is the data on self-reported adherence, and so people have to respond to this 4-item measure on medication taking behaviors. And if they say yes to any of the questions, they're considered to be not adherent. So you can see about anywhere from almost 60 to 70% of people said they were already adherent at baseline. It improves over time, but there's no difference across the intervention groups in adherence, in self-reported adherence. But in systolic blood pressure, you can see that when you look at the overall population, so we didn't take people who were uncontrolled. We just took all people with hypertension. We don't really see a significant difference in blood pressure reduction over time. It looks like a kind of a clinically significant reduction in this group where, the patient got coached, but the doctor actually didn't get trained. But when you look among people who were uncontrolled, you can see pretty large effects in terms of change in diastolic blood pressure here compared to the minimal group. So, and it's been suggested that changes of 5 millimeters of mercury or more are really significantly related to reduction in cardiovascular risk of cardiovascular events, so things like having a heart attack or a stroke. So what are the limitations of this study? So first, the loss of follow-up among the randomized physicians limited the number of patients that we could recruit. We also failed to reach our patient recruitment target, and that reduced our statistical power to look at our primary outcomes. I didn't even talk about what we had hoped to do was to get administrative data on appointment keeping, but because of the resource limitations of many of the practices, we were really unable to get that information, so we had to rely on the patient self-report data. We also, the sample size precluded any subgroup analyses. There were retention and execution challenges, which were fairly significant, and for the intervention exposure for the clinicians, it was basically that one-time 2-hour program, and then for the patients, it was just that one in-person contact. The rest of it was done by telephone, and then we had no objective measure of patient adherence, as I mentioned. So what are some of the strengths? We incorporated some successful features of previous interventions, some of the communication skills training pieces and the community health worker approach, but we also used a novel element. So, for example, community health workers had actually not been used as coaches before in order to enhance cultural relevance. So that was a novel element. And also what was novel is that we intervened on both the physician and the patient sort of in tandem to support the partnership and the relationship. And we also honored the requests of the clinicians to have a self-administered program. A lot of these previous studies have involved doctors having to go to courses that are like off-site that take like half a day, and people wanted something that they could do self-administered on their own time, and they wanted to get individualized feedback. And this is considered to be a community-engaged approach. So what we conclude is that interventions that enhance physicians' communication skills and activate minority and low-income patients to participate in their care are more effective at improving patient-centeredness, and they improve blood pressure control among these patients to a greater extent than just patient education or clinician education. And basically, we need to do some more work to look at which factors are associated with successful implementation of these types of evidence-based, patient-centered strategies. We need to look at what levels of intensity are needed, what specific components of the training may contribute to improved outcomes, and which subgroups are most likely to benefit. So is it the more the low literate patients? Is it the patients with more comorbidities? For example, is it the physicians who were particularly poor at communicating to begin with? And then future interventions we think should use a socio-ecological model. So one of the things we found is that we're intervening on the patient and on the physician, but there are these larger sort of system level constraints that contribute to whether or not people are able to actually engage in these practices and sustain that over time. So I'm going to just stop and acknowledge. I work with a lot of people for this particular trial. Michael Barr was the medical director of Baltimore Medical System, which was one of the organizations that participated in the study. A large group of federally qualified community health centers. Lee Bone here in the School of Public Health really done a lot of pivotal work with community health workers. She and David Levine as well in community engaged research. Kit Carson is here, and she's my partner in crime and my biostatistician methodologist who keeps me on my toes. And Susan Larson and Deborah Roeder are the communications researchers who helped to develop the intervention program for the clinicians and to develop the tools to evaluate it. So I'll stop and take questions.
Okay, so I have another question. Sorry. So even though the 14 community centers, health centers agreed to participate, many of the doctors in those centers did not agree to participate.
I would say about half.
Okay.
Yeah.
So what do you know about them?
Yeah. So, I think some of those people are probably the people who needed it the most. There were people who just didn't they didn't feel comfortable being taped or observed. They felt like this was like an intrusion on their time. They didn't get paid to do research, that kind of thing. Some of the people who ended up dropping out were people who, for example, I don't want to expose any particular people, but we worked with JAI Medical Group, which is also a group of federally qualified community health centers, and the leader there was like, we're doing this study and it's really important and everyone needs to do the study. So everyone said, sure, we'll do it. And then when we went to do it, they were like, well, I'm not really doing the study. So some of that happened as well. So I think, it's possible that we actually got some people who were pretty motivated, and which happens a lot in trials. So.
Well, and possibly among the patients too, especially the ones who stuck it out to the end.
Yes, you're right. You are right. We did have people once they got there seemed to be okay with kind of sticking things through, but I think there were probably a lot of people who all those people who said they would do the study but then didn't show up. They were probably the people who needed this the most too. So we probably ended up with people who were already fairly adherent or had a decent relationship with their physician. But again, what we're trying to do is we know that even among people who have a regular doctor, that control is still suboptimal. So it still makes sense to work with this group, but there may be some other strategy that's needed for those other types of patients that are not engaged at all within the healthcare system. It may be something that needs to be more of an outreach type intervention or something that's more community-based and not practice-based.
How often did the doctor see the patient?
Yeah. So, so with hypertension, it's thought that maybe between every 3 to 6 months, depending on how well controlled the patient is. So it varied, so some people were in more frequently than others. When we got the patients in for their follow-up interviews, we asked them, whether they had seen the physician since the last time we spoke to them. So we had an idea of, and if they had, then they would answer a series of questions about how their last visit had gone.
So there were only two series of questions, the baseline and the...
There was a 3-month follow-up as well. Now, the primary endpoint was 12 months, but we did do some sensitivity analyses where we actually included the 3-month, and they didn't change the the results significantly. There's a question in front and then one in the back.
Thank you very much for your presentation. Very interesting. I have two quick questions. Number one, on the intervention, how specific what was the intervention material to addressing hypertension-related issues, and could that easily be modified for something other chronic diseases that are commonly seen in minority populations?
Right.
And my second question is, early on in your presentation, you mentioned the lack of including minority populations in traditional trials, and I was wondering if you could speak to any efforts that are trying to increase that and minority populations in all studies.
Yes. Okay. So the intervention was not very disease oriented, although it did mention things about cardiovascular health, in the newsletter, for example. But the coaching is it's one of those things where it's more of a behavioral model that it could be applied to any disease, really. It was more along the lines of having people prepare questions, having them practice how they're going to disclose like a particular concern. And so it didn't have to be specific. It was more focused on the process than it was on the specific disease. And the community health workers said, like, a lot of the issues they dealt with had nothing to do with high blood pressure when they talked to the patient. It was like other things related to stress in their lives and other medical issues they had, and needing like work and financial issues. And so, but just in encouraging the patient that they could share those kinds of issues with the doctor and let them know how it was impacting their ability to follow through on the hypertension plan was helpful. So then, in terms of other efforts to involve minorities in research, I mean, that's why in some ways we talk about using a community engaged approach. So like right now, I have a center to reduce cardiovascular disparities. I'm going to tell you one of the main pieces of our center is that we have a community advisory board that guides all of our research. So a lot of the community members were involved even in the writing of the grant proposal and in helping us prepare responses to reviewers. And they meet with us quarterly. They comment on all of our recruitment materials, like where are we going to recruit, what kind of language are we using on the posters and the flyers, who's doing the recruitment, and so they give a lot of suggestions about where to recruit, how to get the word out to the community, like where to post the flyers, where to post the announcements, what radio stations to use. So I think having community members involved, like for wherever you plan to do the study, whatever neighborhood it is, the organizations that might be impacted, patient advocacy groups, neighborhood associations, faith community members, all those people have a much better idea of what's important to the potential research participants and what they would find acceptable. So more so than we do. Especially once we've been trained in our research and medical culture, we tend to change the way we talk and act, and next thing we know, people don't understand anything we're saying, and so I think that just helps to keep us grounded and focused on the populations, and I think that's been recommended in a lot of the research moving forward to do that. And then also hiring, so we've had community members, for example, to actually lead focus groups. You can hire community members to be involved on the research team, to act as interventionists, so community health workers, to act as data collectors. That makes it more likely that people will feel comfortable participating, and that they can actually trust that the research is going to be used to help them, and not something that, again, where there's this legacy of mistrust in the research and healthcare enterprise, legitimately because of things that happened in the past. So we've got to do some extra work to overcome some of those things.
Well, I'm sorry.
There was one question in the back.
You mentioned a little bit about the sample size and subgroup analysis in the discussion, so I wonder if you can speak a little more about the sample size and how power of the study, specifically what was the outcome that the sample size estimation was based on. And then you also mentioned about factorial design. So what was the additive effect or interaction
Yeah.
you're trying to test?
Okay, so the study was powered to detect differences in appointment keeping behavior across intervention groups. But unfortunately, like I told you, we were unable to get the data on appointment keeping behavior. There were several things that contributed to that. Number one was not having the administrative data from all of the sites, but two, a lot of things were changing in healthcare during the time of the study. So like several of the sites we were working at, they shifted to an open access system in the middle of the study. So they decided that, they had such high no-show rates that what they would do is just basically people could call the same day and come in. So it got to the point where people didn't really have appointments. So we really couldn't track appointment keeping because they could just come in whenever they wanted to. So we didn't end up having the power to, we didn't even have the outcome to actually assess that. And so we thought we might have been powered to detect like a 5 millimeter difference in blood pressure, but we didn't reach our recruitment target. So because of that, even though we see the large clinical effects, they don't reach statistical significance. So, and then the factorial design, we couldn't really tell whether we had hoped to be able to determine whether the clinician training by itself or the community health worker coaching by itself was more or less effective than the other, and whether the combined intervention was more effective than either of the others compared to the minimal, but we weren't able to because of the sample size. So the only difference that we could actually show was that the most intensive group combined seemed to be better than the minimal group. But if you just look at the actual effect size, it looks like neither the physician communication skills or it looks like they sort of are comparable, but on the blood pressure reduction, it looks like actually the coaching had a more significant effect on blood pressure reduction than the physician training did.
Thank you. We've run out of time, but if people have individual questions, maybe they'll ask you. But thank you very much.
Thank you.
Very helpful.